Good afternoon. My name is Ian Bowers. I'm a PGY4 in the Mclaren Oakland Hospital ENT program. The title of my project is Diagnosis and Treatment of Laryngopharyngeal Reflux in the Osteopathic Otolaryngology Community, a national level study. Laryngopharyngeal reflux occurs when retrograde flow of gastric contents above the upper esophageal sphincter causes inflammatory tissue changes. The most common symptoms are listed there, along with the most common signs. The prevalence of LPR, it's estimated that up to 20% of new patients present to the ENT clinic with complaints that could be related to LPR. The cost of LPR is estimated to be about $50 billion to the United States healthcare system each year. In 2002, the American Academy of Otolaryngology Head and Neck Surgery, the AAO-HNS, came up with guidelines about LPR in regards to diagnosis and treatment. They say that the diagnosis can be made on symptoms alone, and that no adjunctive testing is needed at the initial diagnosis. The treatment is suggested that the majority of patients with LPR require twice daily proton pump inhibitors, or PPIs, for at least a trial of 6 months. There's been a number of previous surveys of different subgroups of otolaryngologists in the United States asking about the diagnosis and treatment trends, but none of them include DOs as a different subgroup. So doctors of osteopathic medicine go through a different training than their allopathic or MD counterparts. The American Osteopathic Colleges of Ophthalmology and Otolaryngology Head and Neck Surgery is the college for the DO otolaryngologists in the United States. The purpose or aim of this study is to determine the current clinical practice trends in LPR management among members of the college in the United States. The knowledge gained in this study will serve as a baseline to develop educational material pertinent to LPR diagnosis and treatment for the members of the college. Our research question is, how is LPR being diagnosed and treated by the AOCOOHNS members? Do they feel like their osteopathic training influences their management of LPR? And our hypothesis is that based on previous surveys of other ENT communities, it's hypothesized that the methods for the diagnosis will follow the guidelines, while management and treatment will greatly differ and not follow the guidelines. So we did an observational cross-sectional study. It was active members of the college. Exclusion criteria were those who only treat pediatric patients and those who do not treat throat complaints in their office or retired members. We sent out a recruitment email, study information, survey link through the college as an anonymous survey of 29 questions. There's a number of different types of questions in it. It was opened in 2021. We had IRB approval through the IRB at Mclaren, Oakland. For statistical analysis, we did, to describe the characteristics, we did means, frequencies, and percentages. We also did bivariate analysis of different subgroups, including one-way ANOVA, t-test, and Fisher's exact test for the different subgroups. And we used 95% as our confidence intervals. So this, you can see, is our demographic information. So we had 582 active members. We had 49 respond. So it was a response rate of 8.4%. 46 respondents met the inclusion criteria and completed the study. You can see there that we broke it down by number of years in practice setting, and fellowship training, whether they had it or not. So you can see that the most common way of diagnosing LPR is done without adjunctive testing. The majority of our respondents use the flexible fiber optic laryngoscopy on their initial presentation to make the diagnosis of LPR. And only 4 typically order the pH probe testing, which is the gold standard according to the guidelines, but that's only to confirm a diagnosis when the diagnosis is in question. So we also see here that this is the first line treatment that's typical for our respondents. And what this is demonstrating is that there's a wide range. So I offered all the different types of combinations of medications that they could give. And so there's a lot of different strategies that our respondents are using. But the only medications that are described in the guidelines are PPIs, or proton pump inhibitors. So in these figures here, you can see the typical first line treatment and duration next to it, and then the typical second line treatment. So like when their first line treatment fails. And you can see that only 16% of our respondents used twice daily PPIs, and up to 28% did not use them at all on their first line treatment. And the duration, only 2.2% gave their initial duration of treatment for 6 months or greater. So the recommendations from the guidelines are twice daily PPI for at least 6 months. The number of people prescribing twice daily PPIs increased quite a bit for the second line treatment, but we still see that there's a good deal who do not. When also asked about how they feel like their osteopathic training affects their diagnosis and treatment of LPR, the vast majority felt like it had very little influence on their diagnosis and treatment of LPR, and the majority responded that they did not feel like their treatment differed at all. In conclusion, we compared our findings with those of previous studies and found that we had similar results, meaning the diagnosis, which comes as a diagnosis, it's mainly done on the basis of symptoms without a lot of adjunctive testing being ordered right away. So that goes along with the guidelines. But we did find that the majority do not follow the guidelines when it comes to treatment choice. So twice daily PPIs we did not follow the duration either, with only 2.2% prescribing for 6 months or greater. Some of the limitations of this study, we had a low N. We were hoping to get more responders, but this could have been due to being within the COVID-19 pandemic. It could have been due to the survey setup, the number of questions, maybe some confusing questions. And there could also be some responder bias, that those who responded to the emails may be more tech savvy, maybe a younger generation. But when we did bivariate analysis on the different subgroups based on years in practice, we did not note any significant differences. So this will conclude my presentation. I thank you for your time and for judging the presentations for us. Thank you.